Okay, we're going to get started. This is the last day of good weather. Fall returns tomorrow. And Wyndham Wilson couldn't be here today, but in his place we have Kieran Dunleavy from the Metabolism Branch, and he's going to lecture on us about lymphoma. Kieran.
Thank you for the introduction, Terry. So I work in the Metabolism Branch of the National Cancer Institute, and I'm an oncologist who has an interest in clinical lymphoma research. So over the next 45 minutes or so, I'm going to discuss lymphomas. First of all, I'm just going to give a general overview of lymphomas, and then I'm going to talk specifically about some of the research that we're doing in lymphomas at NCI. And this talk is going to focus on non-Hodgkin lymphoma, which is much more common than Hodgkin lymphoma. So there are about 70,000 new cases of non-Hodgkin lymphoma in the US every year. Most people who develop non-Hodgkin's lymphoma are older people. For people under 65 years, the incidence is 8.1 per 100,000. But for people over 65 years, it's 68 per 100,000. And a lot of this talk will focus on the most common type of non-Hodgkin lymphoma, which is called diffuse large B-cell lymphoma, or DLBCL. And the median age at diagnosis of DLBCL is actually 67. Shown here are data from the NCI SEER database, and it shows the incidence rates of non-Hodgkin lymphoma over the last 20 years. And over that period of time, the incidence of non-Hodgkin lymphoma has been increasing in males. It's stayed pretty much the same in females. And as you can see, overall, non-Hodgkin lymphomas are much more common in men. There are several reasons for this. One of them is that people who have HIV have got a much higher increased risk of developing lymphoma. The most common type of lymphoma, diffuse large B-cell lymphoma, is about 100 times more common in people who are HIV positive. And Burkitt lymphoma, a rarer type of B-cell lymphoma, is about 1,000 times more common in people who are HIV positive. So this explains somewhat why the incidence of NHL is much higher in men. And shown here are NHL death rates over that same time period. And as you can see, the death rate from NHL is decreasing significantly in both males and females. So what are the causes of lymphoma? Well, for most patients who develop lymphoma, we don't identify any cause, but there are certain things that are associated with an increased risk of developing lymphoma. One, as I've mentioned, is altered immunity. So people can have inherited immunity disorders like the Wiskott-Aldrich syndrome that's associated with an increased risk of lymphoma. As I've said, patients who are HIV positive have got a much higher risk of B-cell lymphomas and a slightly higher risk of T-cell lymphomas. Lymphoma may be caused by iatrogenic things like bone marrow transplantation or after certain high-dose chemotherapies. It can be caused by autoimmune stimulation. Some patients with lupus and Sjogren's are at increased risk of developing certain lymphomas. And acquired immune stimulation is also associated with an increased risk of lymphoma. Helicobacter pylori infection is associated with an increased risk of lymphomas of the stomach, and hepatitis C has been associated with an increased risk. We don't understand the role of chemical exposure too well, but it does appear that certain organic solvents that are used in agriculture chemicals are associated with an increased risk of lymphoma. And shown here are a number of different types of lymphomas and the etiologic agent that's associated with them. The Epstein-Barr virus is associated with a lot of different lymphomas. About 40% of patients who develop Burkitt lymphoma have an association with EBV, and you can find EBV in the tumor cells. EBV is also associated with Hodgkin's lymphoma and with post-transplant lymphoproliferative disorders. HIV, of course, is associated with AIDS-related non-Hodgkin's lymphomas. There's a disease called adult T-cell leukemia and lymphoma You see this in patients from certain geographical regions, particularly the Caribbean, and that's associated with the HTLV1 virus. Another virus called human herpes virus 8 is associated with the primary effusion lymphoma. Hepatitis C is associated with lymphoblastic lymphoma. As I said, Helicobacter pylori, which is common, is associated with gastric malt lymphomas. So how are lymphomas diagnosed? Well, lymphomas are neoplasms of lymphocytes, and lymphoma really encompasses probably over 80 different diseases. And lymphomas are classified according to whether they are of B-cell origin or T-cell origin, and also the appearance of the tumor cells. The molecular features, which specific genes are involved, are also important, as are clinical features, so the patient's clinical history and the sites of disease. So shown here is the breakdown of non-Hodgkin lymphoma. And as you can see, about 40% of non-Hodgkin lymphomas are diffuse large B-cell lymphomas. And much of the focus of this talk will be on DLBCL. The second most common type of lymphoma is follicular lymphoma. But other lymphomas, like you've probably heard of mantle cell lymphoma and small lymphocytic lymphoma and T-cell lymphomas, anaplastic large cell lymphoma and angioimmunoblastic T-cell lymphoma, these are all rare compared to the two major types, diffuse large B-cell lymphoma and follicular lymphoma. And different lymphomas arise from different stages of B-cell differentiation. So CLL arises from a naive B-cell. Certain lymphomas are associated with germinal center B-cells, such as follicular lymphoma and a type of diffuse large B-cell lymphoma called a germinal center type. Whereas other lymphomas and diseases like the activated B-cell type of diffuse large B-cell lymphoma and multiple myeloma are post-germinal center diseases. And when a patient has lymphoma and the pathologist looks at the tissue, they have various immunophenotypic markers that they look at, and these help them to figure out which type of lymphoma a patient has. You've probably heard of CD20. That's a marker that's present on B-cell lymphomas, but then there are others that are present on T-cell lymphomas and others that are specific to certain types of B-cell lymphomas. So these are all very helpful in helping the pathologist to make the definitive diagnosis. And then when we see a patient with newly diagnosed lymphoma, the staging system that's used is called the Ann Arbor staging system. And this is divided up into 4 different stages, depending on how extensive and how much the lymphoma has spread. Stage 1 is where you have involvement of just one lymph node region or one extralymphatic organ or site. Stage 2, involvement of 2 or more lymph node regions on the same side of the diaphragm. Whereas stage 3 patients have disease on both sides of the diaphragm, and stage 4 patients have diffuse or disseminated involvement of more than one extralymphatic organ or tissues with or without lymph node enlargement. And when we see new patients with lymphoma, we think of something called the International Prognostic Index, because this stratifies patients into good risk categories and bad risk categories. And there are 5 IPI characteristics that we look at. The first is age. So patients who are over the age of 60 have a worse outcome than patients under the age of 60. The next is tumor stage, whether it's stage 1 or 2, which is good, and stage 3 or 4 is bad. The number of extranodal sites, if it's less than or equal to 1, that's good. If it's over 1, that's bad. There's something called the ECOG performance status, and that is graded from 0 to 4. So having a low status means that somebody is very active and not affected by their disease, whereas having a high number means that they're bedbound and not very mobile. And the 5th IPI characteristic that we look at is the serum LDH level. And if that's abnormal, that's associated with a poor prognosis in patients with lymphoma. And in terms of which lymphomas are curable and which are not, diffuse large B-cell lymphoma is curable in up to about 50% of patients. Classical Hodgkin lymphoma is curable in about 80% of patients. T-cell lymphomas, with the exception of one type called anaplastic large cell lymphoma, which is curable in about 80%, but other T-cell lymphomas are only curable in about 20% of patients. So the focus of this talk is really going to be on diffuse large B-cell lymphoma. And over the past 30 years, the most significant advance that has been made in this disease has been the addition of a monoclonal antibody called rituximab, which is against CD20, to a chemotherapy platform called CHOP, which was developed in the 1970s. So about 20 years ago, the GELA group in France, they did a study in patients over the age of 60 years who had a new diagnosis of diffuse large B-cell lymphoma. And they randomized patients to receive either CHOP or CHOP with rituximab because they hypothesized that adding rituximab may improve cure rates. And as you can see from these Kaplan-Meier curves, and this is the GELA study with long follow-up of up to 10 or 11 years, there remains a significant survival advantage for patients who receive R-CHOP over patients who receive CHOP. And these are older people. So the cure rates with younger people are better, but remember that most people with diffuse large B-cell lymphoma are over 60. Shown here are outcome of younger patients. But you can see that patients who have low, intermediate, or intermediate high-risk disease, according to the IPI, have still got a poor outcome. So the bottom line is that there's a very high proportion of patients for whom standard treatment is ineffective. So there's a lot of room for improvement in diffuse large B-cell lymphoma therapeutics. And one of the most significant advances that has happened in diffuse large B-cell lymphoma molecularly has been the dissecting down of this disease into molecularly and clinically distinct subgroups by gene expression profiling. And this was led by Lou Statt at NCI and the Lymphoma and Leukemia Molecular Profiling Project. And they, with gene expression profiling, showed that DLBCL is not just one disease, but it's at least 3 diseases. And they identified an activated B-cell-like DLBCL, a germinal center B-cell-like DLBCL, and another disease called primary mediastinal B-cell lymphoma, which is a type of diffuse large B-cell lymphoma. But if you look at its molecular identity, it is much more close to that of classical Hodgkin lymphoma than it is to these other subtypes of diffuse large B-cell lymphoma. And all 3 of these subtypes correspond to different stages of B-cell differentiation. So germinal center B-cell diffuse large B-cell lymphoma arises from a germinal center centroblast, whereas activated B-cell lymphoma arises from a plasmablast that's blocked during plasmacytic differentiation. And primary mediastinal B-cell lymphoma arises from a thymic B-cell. And all 3 of these entities are characterized by different mechanisms of oncogenic activation. So the GCB subtype is the most common type, and it's the type that children almost always have, and it's the type that's almost always seen in younger people. But this has certain genetic abnormalities. For example, a high proportion of cases have got a BCL2 translocation, whereas the ABC subtype is characterized by constitutive activation of the NF-kappa B pathway, and that inhibits apoptosis. And I'll talk about some of the trials that we've been doing at NCI, but they've been particularly trying to target NF-kappa B. And primary mediastinal B-cell lymphoma is characterized by increased expression of NF-kappa B target genes, as well as increased expression of Janus kinase genes. And this division into 3 different groups is not only important molecularly and in terms of how these different groups have distinct mechanisms of oncogenic activation, but it's also important clinically because patients who have the ABC subtype with current therapy, as you can see, have got a much worse outcome than patients who've got the GCB subtype. So their cure rate is much less with standard treatments. These are patients with newly diagnosed diffuse large B-cell lymphoma who receive the R-CHOP regimen, and this is their progression-free survival. So the take-home message from all of this in terms of trying to develop new treatments for lymphoma is that there's a real need to particularly improve the cure rate for patients who have ABC diffuse large B-cell lymphoma. And we've been doing a lot of work to try to better understand why these patients have a worse outcome and to develop treatments that are specific to the ABC subtype. And I will also talk about PMBL, this third subtype. So I'm going to break up this talk into targeting subtypes of diffuse large B-cell lymphoma. First of all, I talk about how we're targeting GCB. And one very important target in GCB lymphomas is BCL6. Then I'll talk about ABC diffuse large B-cell lymphoma, which is associated with a worse outcome, and NF-kappa B is very important. And then I will finally talk about PMBL and what we've been doing to specifically target that. So BCL6 is a protein complex that is located on chromosome 3. And it's a transcriptional repressor of many target genes that are involved in apoptosis and the DNA damage response. And shown here are several cases of diffuse large B-cell lymphoma. And we looked at the expression of BCL6 in these cases. And you can see that in GCB diffuse large B-cell lymphoma, BCL6 is very highly expressed. Red is high expression, green is low expression. But in the ABC type of diffuse large B-cell lymphoma, the expression of BCL6 is very low. So this shows us that it's an important target in GCB lymphoma, but not in ABC lymphoma. And why is BCL6 important? Well, in the germinal center, BCL6 inhibits the cell cycle arrest genes P21 and P27. And it also inhibits P53 ATR. And what does this do? It reduces the DNA damage response, and this leads to increased tumor proliferation. And shown here are different ways that we are trying to specifically target BCL6. The acetylation of BCL6 is highly dependent on HDAC and SIR2 pathways. So there are therapeutic strategies that are being tested that inhibit these pathways in an attempt to target BCL6 with HDAC inhibitors and SIR2 inhibitors. There are small molecule inhibitors of BCL6 in development. One of these is called 796, and it binds to one of the co-repressor binding domains of BCL6 and inhibits it in this way. And in the lab, this has been very successful, and it is in the process of going into clinical trials in humans. And there are other small molecule inhibitors in development as well. Etoposide is an interesting drug when we talk about targeting BCL6. Cells in the germinal center are highly proliferative, and they're very dependent on an enzyme called topoisomerase 2. And etoposide inhibits topoisomerase 2. And at the NCI, we've done a lot of work and developed the dose-adjusted EPOCH-R regimen for aggressive B-cell lymphomas. And unlike CHOP, which I mentioned at the beginning, that's the standard regimen for patients with this disease, dose-adjusted EPOCH incorporates etoposide. Shown here are the schedules. 3 of the drugs are continuously infused over 4 days. Rituximab is given on day 1, and cyclophosphamide is given on day 5. But it's interesting. This is a study, a multi-center study of the dose-adjusted EPOCH-R regimen in DLBCL. And you can see that in 68 patients, the progression-free survival was 81%, and the overall survival was 83%. But what was really interesting when we looked at the breakdown of response and survival in terms of cell of origin, we found that patients who had the GCB subtype had a much better outcome. 100% of them were progression-free versus 67% of patients with the non-GCB or ABC subtype. And this really suggests that adding etoposide is beneficial in germinal center diffuse large B-cell lymphoma. This is a study called the MINT study, which was done by a German group. And a number of years ago, they compared CHOP with CHOP plus etoposide in newly diagnosed young patients with diffuse large B-cell lymphoma. And they found that patients who received etoposide had a significant survival advantage. And again, this suggests that adding etoposide is important in the germinal center type, because the proportion of patients who have germinal center lymphoma in the age group under 60 is much higher than in the age group over 60. When they added rituximab to CHOP, they didn't see this benefit. But at the same time, the fact that they did see it without rituximab is very interesting. So in conclusion, with regard to GCB, diffuse large B-cell lymphoma, high genotoxic stress decreases BCL6 in vitro. There is a benefit to adding etoposide in younger patients, and that may be due to a higher percent of GCB tumors. Dose-adjusted EPOCH-OR may produce high genotoxic stress. There are ways that you can specifically target BCL6. I mentioned HDAC inhibitors and SIR2 inhibitors and peptomimetic inhibitors of BCL6, like the 796 agent that I mentioned. Another important target in the germinal center tumors is EZH2. This is mutated in about 25% of GCB, diffuse large B-cell lymphomas, and inhibitors of it are toxic to GCB cell lines. So this is potentially an important target for future clinical drug development. So next I'm going to talk about targeting ABC, and this is the subtype with the worst outcome with current treatment. And one very important thing about the ABC subtype is that there is constitutive activation of NF-kappa B. So shown here are a number of NF-kappa B target genes, and the expression of these genes in ABC versus GCB, with green being low expression and red being high expression. And as you can see, these genes are highly expressed in the ABC and lowly expressed in the GCB subtype. So the NF-kappa B complex is a potential target for future strategies. And a number of years ago at the NCI, we wanted to try to specifically target the ABC subtype. So this is work that was done by Lou Stat in his lab. They tested both GCB and ABC cell lines, and they treated them with an inhibitor of NF-kappa B. It was called a MLX105. It was an I-kappa B kinase inhibitor. And they found that ABC cell lines were very sensitive to this, whereas GCB cell lines weren't. So this validated NF-kappa B as a therapeutic target in diffuse large B-cell lymphoma. So we would have liked to have done a study with an I-kappa B kinase inhibitor, but there wasn't one commercially available at this time. But another agent called bortezomib was available. Bortezomib blocks the degradation of phosphorylated I-kappa B when it enters into the proteasome. And at the time that we conceptualized our study, there was no data using bortezomib in diffuse large B-cell lymphoma. So we wanted to specifically target the ABC subtype and see if adding bortezomib was more helpful for those patients than the GCB subtype. So we accrued patients with relapsed and refractory diffuse large B-cell lymphoma. We had 49 patients in our study altogether, and we tried to do gene expression profiling to molecularly classify if they were GCB or ABC. And if it was not possible to do this, we used immunohistochemistry to predict whether they were GCB or ABC. There are now several immunohistochemical algorithms that look at markers like CD10 and BCL6 and MOM1, and depending on if these are positive or negative, they predict with high probability whether it's a GCB or an ABC tumor. So we combine this with gene expression profiling to figure out which type these patients had. We tried treating patients with bortezomib by itself initially, and then if they progressed on this or if they had very aggressive disease at the beginning, we combined chemotherapy with bortezomib. We found that bortezomib as a single agent was not very effective, but bortezomib with chemotherapy was effective. So these are the results of our study we had response information on 44 patients. And what was really interesting was that the response rate in patients with the ABC subtype was 83% and 13% in patients with the GCB subtype. So this was highly statistically significant. And when we looked at overall survival, patients with the ABC subtype had a median survival of 10.8 months versus patients with the GCB subtype had a median survival of 3.4 months. So this was highly significant. And when you look at these curves, you may say these survivals aren't very good, but these were patients who had received a lot of prior therapy. A lot of them had received a bone marrow transplant before. The median number of prior chemotherapy regimens was 4. So these were heavily pretreated people. But this was what we had hypothesized, that by adding a specific inhibitor of NF-kappa B, we could really improve the outcome of the ABC subtype. And then we asked ourselves the question, well, could it be that when patients with diffuse large B-cell lymphoma relapse, for some reason, those with the ABC subtype do better? So we went back to another study of patients who relapsed after R-CHOP, and we looked at their outcome following relapse according to the cell of origin, and there was no difference in outcome as to whether they had GCB or ABC subtype. So we really felt that we were seeing a strong signal in our study. And as a result of our study and another study that was done at Cornell in newly diagnosed patients, there are now 3 studies ongoing that are looking at adding bortezomib to rituximab and CHOP in newly diagnosed patients and answering the question, is that going to benefit patients with the ABC subtype? But since the time that we did our study, our understanding of how NF-kappa B is activated has evolved significantly. And most of this work has been done by Lustat and the Lymphoma and Leukemia Molecular Profiling Project. We've understood the terminal portion of NF-kappa B activation for quite some time, where phosphorylated I-kappa B enters into the proteasome. But what happens upstream of that has really only been recently elucidated. We now know that about 10% of ABC lymphomas have got a mutation of CARD11. And over the past few years, we've learned that upstream of this, about 21 or 22% of patients with ABC lymphomas have got a mutation in the B-cell receptor. There's another complex called MyD88. The Lymphoma and Leukemia Molecular Profiling Project surveyed this pathway. It can activate NF-kappa B through IRAK4 and IRAK1 signaling. But they found that in ABC lymphomas, about 29% of patients have got a mutation of MyD88. So this is really interesting that a very high proportion of patients have got B-cell receptor mutations and MyD88 mutations. And this is important in terms of thinking about new treatments because these pathways can potentially be targeted. So as I've said, B-cell receptor and MyD88 signaling are both very important activators of the NF-kappa B pathway. And one enzyme in the signaling cascade in chronic active B-cell receptor signaling is called Bruton's tyrosine kinase. And Pharmacyclics, a company in California, developed a drug called ibrutinib, which is an inhibitor of Bruton's tyrosine kinase. Ibrutinib covalently binds to the BTK active site. And shown here are cell line studies. These are ABC cell lines that were treated with ibrutinib. It was selectively toxic to these, but it wasn't toxic to GCB cell lines. And it's interesting that it also wasn't toxic to ABC cell lines that were CARD11 mutant because that's downstream of BTK, which would make sense. So we've been involved in a multi-center study, a phase 2 study of this drug in patients with relapsed and refractory diffuse large B-cell lymphoma. They received a dose of 560 milligrams per day until they progressed. And the objective of the study was to evaluate their response and look at response rate in ABC versus GCB, diffuse large B-cell lymphoma. And the secondary objective was to evaluate the safety and tolerability of ibrutinib. And patients were stratified into separate ABC versus GCB cohorts by central gene expression profiling. So this study has not been published yet, but they were presented last year at ASH by Dr. Wilson. And overall, the response rate in the study was 23%. 14% of patients had a PR, and 9% of patients had a CR. But what was really interesting, if you look at response rate according to whether patients were ABC or GCB, the response rate in ABC patients was 41% versus just one patient with GCB. And this is in line with our understanding of how this drug works in targeting BTK, which is important in the NF-kappa B pathway, which is constitutively activated in the ABC subtype and not in the GCB subtype. And also as part of this study, we're looking at B-cell receptor mutations and MYD88 mutations, and a high proportion of patients who respond have got either a mutation in B-cell receptor signaling or MYD88 or both. This is the PET-CT scan of one of the patients on the study before and after they received ibrutinib. This patient had received multiple chemotherapy regimens before, to which they had not had a good response. And as you can see, after 3 weeks on ibrutinib, their disease, which was mainly intra-abdominal, has significantly decreased on this PET scan. So as a result of all of this, one of the most important studies that is now ongoing in diffuse large B-cell lymphoma is a study of R-CHOP versus ibrutinib with R-CHOP in newly diagnosed patients with diffuse large B-cell lymphoma. And to be eligible for this, their disease needs to be histologically confirmed non-GCB DLBCL or ABC DLBCL. They have to be 18 years or older, no prior history of indolent lymphoma, and no primary mediastinal lymphoma, which is the third subtype of lymphoma, which I'll talk about at the end of this talk. And if they meet these eligibility criteria, they're randomized to either receive R-CHOP and placebo or R-CHOP and ibrutinib. And this study is ongoing in very many centers, and the total accrual goal is over 800 patients. And the company that are sponsoring this study expect that that will be finished in 3 to 4 years. So in conclusion, with regard to ABC, diffuse large B-cell lymphoma, the B-cell receptor mutations are found in over 20% of patients, and they can lead to chronic active B-cell receptor signaling, which is important in activating NF-kappa B. 10% of patients have got CARD11 mutations, over 20% have got MYD88 mutations. Patients can also have 820 inactivating mutations. And strategies that target the B-cell receptor, the toll-like receptor complex, and NF-kappa B are all under study. I've talked about ibrutinib, but there are other drugs that are being developed at the moment. Enzostarin and sotastatin are inhibitors of PKC-beta. There's a drug called CAL-101, which inhibits PI3 kinase. Other inhibitors of NF-kappa B, bortezomib I mentioned, and MLN-4924. Lenalidomide is an immunomodulatory drug which works in about, or is effective in about 30 or 35% of patients with the ABC subtype. And IRAK4 inhibitors are in development as well. So next I'm going to talk about targeting PMBL, which is the third type of diffuse large B-cell lymphoma. If you look at the molecular profile of PMBL, it has a lot more in common with classical Hodgkin lymphoma than it does with ABC or GCB diffuse large B-cell lymphoma. Actually, if you look at PMBL and classical Hodgkin lymphoma, they share about a third of their genes, so they're biological cousins. And if we look at the spectrum of mediastinal lymphomas, these are lymphomas that present in the chest. At one end of the spectrum, we've got nodular sclerosing Hodgkin lymphoma. And at the other end, we've got primary mediastinal B-cell lymphoma. And we now understand that there exists a continuum of these mediastinal B-cell lymphomas, but there are lymphomas in the middle of this continuum that don't fit into either the box of NSHL or the box of PMBL, and these are called mediastinal gray zone lymphomas. And they have features that are intermediate between NSHL and PMBL, and have immunophenotypic features that are also intermediate between these two entities. And if we look at PMBL and NSHL, it's interesting clinically that they both predominantly affect females. They're usually diseases of adolescents and young adults. They present with a bulky anterior mediastinal mass, and sometimes you see supraclavicular lymph nodes. We don't know a lot about mediastinal gray zone lymphoma, and it's not something that I'm going to talk about too much during this talk, but we've just completed a study in our group of 22 patients with this disease, which will be the largest study of mediastinal gray zone lymphoma because there's very little data out there. But we found that it usually affects males, but is a disease of younger people, and it presents with a bulky anterior mediastinal mass, just like NSHL and PMBL. So the PMBL is a type of diffuse large B-cell lymphoma, but it's really managed in a very different way. Early studies that were mainly done by Italian groups suggested that mediastinal radiation after chemotherapy was a very necessary component of treatment if you wanted to cure people. These studies also showed that dose intensity, there were two regimens that were studied a lot. One was called MAC-UP-B and one called VAC-UP-B. But the Italian groups showed that dose intensity was associated with a better outcome compared to CHOP. But despite this, for the most part, today, this disease is approached like the other types of diffuse large B-cell lymphoma, and R-CHOP is the standard treatment. And shown here is the outcome of PMBL with R-CHOP. This is a German study, and they did a subset analysis of patients with PMBL. It was a study of diffuse large B-cell lymphoma, but they looked at patients with primary mediastinal B-cell lymphoma specifically in their study to see how they did with R-CHOP. And their event-free survival and overall survival were approximately 68 and 78%, but most of these people received mediastinal radiation. And that's key as to what I'm going to talk about over the next few slides. And if you look at, this is another study that was done by the Mass General group. And again, they looked at all of their patients with PMBL over a 10 or 12-year period and found that the overall cure rate with R-CHOP was just 68%. And they found that patients with advanced stage disease did particularly poorly. Their cure rate was about 30% with R-CHOP. And again, most of these people received mediastinal radiation. So there are lots of therapeutic challenges in this disease. It's a disease of young patients with a female predominance. It's associated with a good prognosis. But one of the big problems is that standard treatment usually includes consolidation radiation. And I'm sure that you're aware that this is associated with a significantly increased risk of secondary tumors and an increased risk of ischemic heart disease. We now have lots of studies from children who were treated 20, 30, 40 years ago with mediastinal radiation, and we've been able to look at their long-term outcome and what they're at risk of as they get older. And in one of those studies, the 20% of female patients who had received mediastinal radiation as children developed breast cancer. So there's a real need to develop effective treatments that remove this need for radiation, but maintain or even improve upon the cure rates that people have got with combined modality therapy. So we set out to study the dose-adjusted EPOCH or regimen in patients with PMBL. And we gave them 6 cycles of treatment. At the end of treatment, we did a CT and an FDG PET scan. And if the PET scan was positive, we performed a biopsy. And if this showed residual lymphoma, then patients received radiation. If the PET was negative, they went into follow-up. And if the PET was suspicious, we typically repeated it in 4 to 6 weeks. And if the values, there's something called the SUV value on a PET scan, which tells you how active it is. And if that was decreasing, then patients typically went into follow-up. And shown here are the results of our study. We treated 51 patients at the NCI. Most of these patients were females. The median age of patients was 30, with a range of 19 to 52. 65% of them had a bulky tumor, which we defined as a mediastinal mass 10 centimeters or greater. And if you look at various IPI characteristics, they're similar to other studies of PMBL. We also collaborated with the group from Stanford. Their series was retrospective, but they had treated 16 patients with the dose-adjusted EPOCH-OR regimen, and they had similar characteristics to our patients. Shown here are the results of our study. Patients did not receive mediastinal radiation. So at a median follow-up time of 6 years, the event-free survival was 93%, and the overall survival was 97%. And in our study of 51 patients, just 2 people needed mediastinal radiation treatment. So this is the first study that has not used mediastinal radiation in primary mediastinal B-cell lymphoma from the outset, and shown that you can treat these people very effectively without using mediastinal radiation with the dose-adjusted EPOCH-OR regimen. One of the big concerns in treating particularly children with lymphoma is that we use a drug called doxorubicin, and that in high doses has been associated with cardiotoxicity. But in EPOCH, we give doxorubicin as a continuous infusion over 4 days, and we believe that it's associated with much less cardiotoxicity when we do that. So in our PMBL study, we looked at ejection fraction in our patients, and we correlated ejection fraction with the cumulative dose of doxorubicin that patients got and with the time since treatment. And we didn't find a significant correlation with either of these 2 things. So from our study, we didn't see any evidence that there was an increased risk of cardiac problems following infusional doxorubicin. Shown here, as I said, we did an end-of-therapy PET scan to determine if patients needed radiation or not. And this is interesting because we found that if the PET scan was negative at the end of treatment, this was very useful clinical information. The negative predictive value was 100%. But we found that about 50% of patients had a positive PET scan at the end of treatment, but this didn't mean that they had active disease. Most of the time when we followed these patients, the abnormalities on their PET got better. And it's just something that you see when you treat these patients, but it's obviously very important for oncologists to recognize that having a positive PET in PMBL at the end of treatment does not always mean that you have active disease. And in fact, we found that in most patients with PMBL, it did not mean that there was residual disease left behind. This is one of the FDG PETs from a patient on our study. And at the end of treatment, after 6 cycles of EPOCH-OR, she still had a significant abnormality on her PET scan with a maximum SUV of 6. And we observed her, and 6 weeks later, this had reduced to 2, and the subsequent PET was completely normal. So this patient did not receive mediastinal radiation, and the abnormality on the PET was not residual disease, as it improved by itself over the next few weeks. And in terms of diffuse large B-cell lymphoma, we've been involved. This study has been led by Dr. Wilson, and it has just finished accrual, and over 550 patients were accrued to this study, and it compared ORCHOP with dose-adjusted EPOCH-OR for patients with newly diagnosed diffuse large B-cell lymphoma. So the results of this study will be very interesting, and one important component of this study was taking samples for gene expression profiling, and this was done in a high percentage of patients on the study. So in conclusion, in terms of moving forward in diffuse large B-cell lymphoma, is there a better regimen than R-CHOP? I think the randomized study of dose-adjusted EPOCH-OR and R-CHOP will answer this question. But I think we have to think of diffuse large B-cell lymphoma in terms of molecular subtypes. And certainly for PMBL, although dose-adjusted EPOCH-OR has not been compared to another regimen, our results are really excellent without radiation. So for that subset of diffuse large B-cell lymphoma, I think we can do much better than R-CHOP. And potentially in the germinal center type, it appears that dose-adjusted EPOCH-OR is better than R-CHOP, but this will have to be answered in the randomized study that I showed you on the last slide. And it's really important to consider diffuse large B-cell lymphoma as being divided into distinct molecular diseases. And this is important in order for us to develop novel strategies that arise from these molecular insights. And there's an increasing recognition that these subtypes need to be approached differently therapeutically. I think the ibrutinib study that I showed you is really exciting because it shows very nicely that there is a lot of activity in the ABC subtype, but virtually no activity in the GCB subtype. And the R-CHOP plus ibrutinib versus R-CHOP placebo study is very important because it will be really interesting to see if adding ibrutinib can improve the cure rate of patients with ABC lymphoma. And for subtypes with high curability like PMBL, we need to focus on reducing toxicity. So I will be happy to take any questions for the remaining 10 or so minutes of the talk. Thank you. Yes?
Is it standard now that people start coming to like the test or just looking for to be or the new types of, because I wonder if they were all before treated the same or would they still be treated differently now? Anything has shifted.
Yeah, so that's a very good question. So the answer is no. I mean, but we use immunohistochemical algorithms. So when a patient comes and when their tissue sample is analyzed by the pathologist, they look at the morphology, but then they do immunohistochemistry and they look at various markers. And 3 markers that they look at in diffuse large B-cell lymphoma are CD10, MUM1, and BCL6. And depending on whether they're positive or negative, there's a particular algorithm called the Hans algorithm. And you can predict if somebody has GCB or ABC. But it isn't 100%, and there are lots of pitfalls because different pathologists in different centers do things in different ways. Exactly. So in the future, I think that will happen, but it's not something that is done routinely at this point in time. And then in answer to the other part of your question, we don't treat patients any differently, but we do manage patients with the PMBL subtype differently, but they present in a very different way. So exactly. And one thing about we classify lymphomas according to the World Health Organization classification, but in their last update in 2008, they really emphasized that when you're diagnosing these diseases, it's really important to take account of not just the pathology, but how the patient presents and if they have a mediastinal mass. So PMBL, for example, is called a clinico-pathologic diagnosis. So sometimes when we're looking at a case with the pathologist, they'll say this is diffuse large B-cell lymphoma, but if they know that the patient was female and is 25 and had a huge mediastinal mass, then they'll be happy to call it primary mediastinal B-cell lymphoma. And that one is managed differently. But all of this is just changing at a very slow pace. But I think with ibrutinib for the ABC subtype, if the study that's being done with R-CHOP versus R-CHOP and ibrutinib, if it shows that there's a big advantage for the ibrutinib arm, then that will probably become standard treatment in that subtype. Yes?
I think heard a graph there that you combined R-CHOP with another drug and it had actually a worse outcome than the rituximab with it. But this is kind of I don't really know why.
So what I was showing there was that it was when I was talking about the GCB subtype, we think that etoposide may be helpful in the GCB subtype, and our studies have suggested that. But the German groups who do a lot of the large cell lymphoma studies, they compared CHOP with CHOP plus etoposide, and they showed that it was better. Adding etoposide was better, but when they did another study and they added rituximab to either CHOP or CHOP plus etoposide, there wasn't any difference. So rituximab seemed to overcome any benefit of adding the etoposide. But with all of these studies, you always have to remember that although there wasn't a statistically significant difference, it has happened before that one group have showed something and then another group have showed something else. So, and actually there was a study from Denmark that looked at adding etoposide. It was a retrospective study, but also showed an advantage in younger people. So that's what I was showing, that adding rituximab took away the benefit of adding the etoposide to CHOP. Does that make sense? Okay. Yep. Bortezomib, yeah. Okay.
And that thing was patients with subtype, and that was better outcome with that mostly when you do these studies, are patients usually treated with single agent, a single type of treatment, or is it usually in combination like this? And in the future, is it going to be more common to do combinations or single?
Yeah, that's a good question. I mean, I would say both. There are studies, these are relapsed patients. There are studies that just test a single agent and studies that test a single agent with a chemotherapy platform. One thing that we were trying to answer was, does adding bortezomib actually modulate the way that dose-adjusted EPOCH works? So, is there synergy when you do the two of them together? So in our study, we actually had an arm where they got bortezomib by itself, and then they got bortezomib with chemotherapy. But it's a mixture of different things. There are studies with single agents and studies with combinations.
In general, in your opinion, which method seems to be more effective?
I think that both are necessary. The reason we do all these studies is to try to understand if we can specifically target one of these subtypes or if there's a pathway that we can target. But in the big picture, we're trying to figure out which treatments are the best to test in newly diagnosed patients so that we can improve the cure rate for newly diagnosed people. So that's really the goal of all of this work. Although these studies are being done in different populations, at the end of the day, if you have diffuse large B-cell lymphoma and you have the ABC subtype, we want to try and develop a new treatment that's going to improve the cure rate from 30 or 35% to something much higher. So that's the reason that all of this work is being done. But you need single agent studies, combination studies. It's all part of what is needed to move to the next level. Yeah.
Is there any thinking that these different subtypes of DLBCL might be differentially related to immunosuppression?
That's a very good question. We've done a lot of work with HIV lymphomas, and we've looked at different subtypes within people who are HIV positive and have diffuse large B-cell lymphoma. And we do actually, that's a very good question. If people are extremely immunosuppressed, there's a higher risk or a higher incidence of ABC lymphomas. And for example, in people who have HIV at the beginning of the HIV epidemic, when there was no antiretroviral treatment, and the risk of developing lymphoma if you have HIV is extremely high, 100 to 1,000 times more than the general population. But most of the large cell, or a high proportion of the large cell cases that were seen were the ABC subtype. and they had a terrible outcome, and they have a much worse outcome if they're HIV positive as they do if they're HIV negative. So yes, you tend to see more virally driven lymphomas in more immunosuppressed patients as well. So, you probably see a higher rate of EBV-driven lymphomas and different things like that. So, yeah.
Okay, well, that was great.
Okay, thank you very much. Yeah. Yeah, absolutely. I mean, if you have any questions at any point about lymphoma, feel free to email me or any of the group. We're always happy to answer any questions or interact on any level if that's helpful. So, yeah.
Appreciate it. Okay, well, our next speaker is coming from off campus, and he hasn't arrived yet. So we'll just have to wait a few minutes, and hopefully he'll get through the security and be here shortly. Okay, Javed Khan couldn't be here, but we're pleased to have Jun Wei. The title, The Application of Genomics to Identify Diagnostic Biomarkers, Drivers, and Therapeutic Targets for Pediatric Cancer. Jun.
Great, thank you. Thank you, Terry. Yep, great, thank you. Well, thank you, Terry, for the invitation to talk about our research in pediatric cancer in pediatric oncology branch using genomics. So the title of this talk is going to be the application of genomics to identify diagnostic biomarkers, drivers, and therapeutic targets for the pediatric cancer. So this is the outline for my talk today. First, I'm going to go through some background on the success and the challenges of treating pediatric cancers. And of course, I'm going to introduce some concepts of biomarkers, drivers, and therapeutic targets, and especially how to use genomic tools to discover those things in the clinics. And I'm going to give you an illustration with our research using the discovery of FGFR4 in the rhabdomyosarcoma as a case to illustrate my points. And oops, sorry. And then lastly, I'm going to introduce this concept to use translational genomics to hopefully, we try to do the personalized medicine. That's the future of the medicine, so-called. So this slide shows that over the past several decades in pediatric cancer, we have a very good progress in the pediatric cancer treatment. You can see this is the 1960s in blue, the survival rate for the pediatric tumors is pretty low in 60s, but in 90s, you can see most tumors has a high cure rate. So in the past, this kind of cure rate is based on the empirical treatment. You try different agents, through the trial and error, to see which one works, which one doesn't work. So this is all empirical, nothing well, of course there's intellect, but not much into these molecular target things. You can see this curve shows that the mortality rate keep declining in the past about 4 decades. However, recently, after the 90s, you can see those curves, they reached a plateau. That means through the old method using the empirical trial, this approach is not that effective anymore. We reached to a therapeutic plateaus. And especially for certain disease, the metastatic disease, which is cancer already spread, so the cure rate is pretty dismal in those pediatric cancers. So I showed here several cancers with acute myeloid leukemia. You can see that the 60s survival rate is low, and now it's about 50% that we can cure. And the high-risk neuroblastoma only reach about a little bit more than 30%. But look at this brainstem glioma, the survival rate for those patients are very low. And look at the Ewing sarcoma. This is another Ewing sarcoma. This curve represents the localized disease. If it's localized, we can cure the kids pretty well. But if it's metastasis disease, the cure rate is very low. And same story in the rhabdomyosarcoma. Here shows the overall survival and event-free survival curve. It's pretty low. So I give you some definition. So what we want to do in our lab is use genomic tools to find the biomarkers and hopefully identify the drivers and devise novel therapy for those incurable disease. So what's the biomarker definition? So this is from the NIH definition. It's for characteristics that it is objectively measured. You can measure these kind of things objectively, and also used as an evaluation for the indicator of diagnosis, prognosis, a normal biological process, pathological process, or pharmacological response to a therapeutic intervention. And this is the driver definition, is a genomic alteration that is causative to a disease, either for the oncogenesis or tumor survival. Okay, such mutations has been positively selected during the carcinogenesis and often show recurrent pattern within or across tumor types. So those are well studied the genetic disease, genetic change that we are sure those are causative. But on the contrary, there's another type of genomic change we call the passenger event, which is arise from the background mutation. So everybody, as a normal human, we walk around with thousands of genetic variation. Okay, those genetic variation is accumulated through our life. Every time a cell division, there's certain error rate. So we accumulate those things as we go. So the older the people, the more genetic so-called variation we have. But most of them are benign. Okay, those are called passenger mutation. So they arise from background mutations and do not contribute to the oncogenesis. And what we call the therapeutic target is there's two kinds of therapeutic target. One is we can identify the molecules or protein differentially expressed in the tumor that can use to be to homing the therapeutic therapy. Okay, for example, you conjugate antibody towards the antigen specifically expressed on the tumor, so you can deliver your payload, your drugs, your radiation therapy to specific to that tumor. But there's another kind. It's a target, but we can use small molecules, any kind of things that we can do the inhibition, so that or inhibit these downstream molecules, leads to tumor growth suppression, or even regression, or kill the tumor. So these are two different kind of target, but in general, we call them therapeutic targets. I will illustrate the application of this concept in our study. So here is a perfect scenario, okay? You find a biomarker, you can objectively measure it, detect it, and also it has a driver role which is causative to the oncogenesis or key to the survival of tumors. So then we can target those, right? Either use drugs or other methods to target this to specifically kill the cancer cell or tumor cells, but not affect the normal tissues. So that's the ideal scenario. However, biomarker may not be like this, okay? The reason is biomarker may be surrogate or nothing to do with the tumor biology. For example, this is CD99, which is an antigen expressed on the surface of Ewing sarcoma cells. Okay, I mean, you can target as much as you want, but it doesn't hurt the tumor. Okay, tumor growth or survival is not dependent on this molecule. And another category is the driver may not be easy to target. For example, those transcription factors, MECAN, and the PAX3, 4CAT, these are the fusion genes you often seen in the pediatric tumors, and they are functioning as a transcription factor. So it's actually it's extremely difficult to target the transcription factor. And this slide shows you the central dogma. Okay, it's a fancy slide of central dogma. The genetic information usually flow from our DNA to the RNA, eventually translated into the protein, and voila, here we are, as we are, right? And this yellow line divided, this is a genomic domain, and this is a proteomic domain, okay? And you can see all those numbers here illustrate how complicated this system is. It's not as simple as we used to think. You know, it's a simple information flow. Actually, it's very complicated. There's feedback loops. Oops, sorry. These are feedback loops at all different stages, okay? So generally speaking, everybody, we have about 3 billion base pair DNA. Okay, that's our chromosome. Okay, all our genetic information are encoded into our DNA. And on the top of that, the genetic information will go, The genetic information will go through DNA to the messenger RNA. So we have about 25,000 protein coding genes that can be transcribed into the messenger RNA. And on the top of that, there's another complexity is the splicing isoform. Okay, you can have same gene coded with the same nucleotide acid, but the maturity of the messenger RNA, you can be spliced. So you can have different isoform of the same, isoform of the messenger RNA of the same gene. Okay, recently we also discovered that there's a lot of regulatory elements in the RNA species. For example, the microRNA, and now we start to pay more attention to the non-coding RNA. Those mRNA are small RNAs, usually about 18 to 22 nucleotide in length. And they have very important roles to regulate the stability of the messenger RNA. And the non-coding RNA, we don't know the majority of the function of them. Okay, but you can see the number here, it's a lot. I think we're going to discover more. You know, the ENCODE project found that more than 80% of our genome has been transcribed. You know, most of them, we don't know what exactly the function is. Okay, on the protein side, you can see after the messenger RNA being translated into the protein, it's not only 75,000 protein, right? Because you can be modified with phosphorylation, with all this. All other different kind of the modification. So actually, the estimation of the protein species is over 100,000. So this is a very complicated system we have to bear in mind. So the genomic study is focusing only in this domain, and that's what the tools we use to do the research in our lab. Okay, as I said. So here I give you a clinical vignette. This is a diagnostic conundrum really seen in the clinic. What happened is this is like almost like 15 years ago. Okay, there's a child treated in the pediatric oncology branch for the second opinion. Okay, this child has an injury to the groin while playing, and so there's a swollen in his groin part, and then eventually it's just resolved. But so at that initial diagnosis is just a hematoma, so no serious, right? It's just treatment just for the observation. But several weeks later, the mass become bigger and bigger, and they suspect that there's a malignancy, and they performed autopsy on it, biopsy on it, sorry. And this is the histology slides from the biopsy slides. And I don't know how many clinicians in the audience. Personally, I'm not, okay. So they were told that, I was told that this is what it looked like a lymphoma, okay? But it turned out it's not a lymphoma, it's a rhabdomyosarcoma, okay? But you can see this is very hard to tell under the histology slides, okay? So despite the availability of the immunohistochemistry, cytogenetics, and molecular techniques, in some cases, those incorrect diagnosis does happen, okay? So 15 years ago at that time, when the genomic just started, because that is the almost completion of the Human Genome Project, and we have high throughput techniques like microarray start become common in the laboratory. And then at that time, we were asking a simple question saying, can we use genomics to use for better diagnosis, just like this case, okay? And the model we use is this model. As a matter of fact, I just tell you, this case was confused by lymphoma and the rhabdomyosarcoma. As a matter of fact, in this category of rare tumor, there's also another two player, which is Ewing sarcoma and the neuroblastoma. So these four category, people usually call it a very generic term. It's called a small round blue cell tumor. The reason is exactly what you see under the microscope. It's a small round blue cell. Okay, it's named. So what we did is we took 4 of the tumor. Those are all very high malignant pediatric solid tumors, and they are pretty common. Pediatric tumor actually is very rare, but those 4 are pretty common among the pediatric tumors. So we just want to see if we can use genomic tools to do accurate diagnosis, or hopefully the prognosis to predict the outcome for those kids. So this is a paper we published in 2001 in the Nature Medicine. What we did at that time, we're using a very, nowadays look back, this is a very crude microarray, okay? This is a microarray we printed in the lab using cDNA clones. So this is cDNA microarray, which at that time, it's only contained about 6,000 genes. So compared nowadays, the whole genome array, this is like a really, really backward. But at that time, that's the state art of microarray. So here shows the hierarchical clustering of the tumors on this dimension, and this is the genes. In this study, we used the artificial neural network to train and the network to be able to recognize the specific pattern of the tumor, the gene expression pattern of the tumor, so that we can use that to diagnose the tumor. And here is the gene we identified specific to each category of the tumor. And as you can see, this gene is a MYC2. It's also called CD99. This is used in the clinic as a diagnostic markers for the Ewing sarcoma. You can see the gene expression profile shows it's very highly expressed in Ewing sarcoma, but not much in the other tumors. And the same story with the FGFR4. It's highly expressed only in the rhabdomyosarcoma, but not in the other tumors. So in this study, we identified 41 genes not previously reported to be expressed in those tumors. And we can potentially using those gene signature to make a novel diagnostic the kits to diagnose the tumors. As a matter of fact, we collaborated with a company called Althea. This is a small biotechnology company in West Coast. We made a diagnostic kit to be able to use in clinic. And another important thing for biologists is the biology of the tumor. So because we know the specific things, specific genes expressed in those tumors, we can really study the biological effect of those genes in those tumors. And hopefully we can develop some of those into a therapeutic target. Okay, this is another clinical case after we developed this diagnostic kit, the usage of that. So at that time, there's about a young girl need a second opinion from the POB. This girl is treated in Germany, referred by Dr. Udo. And this girl has a 6 weeks history of weight loss, reduced appetite, and fever and abdominal pain. And on examination, there's a big mass on the left side of the abdomen. And this is a CT scan. You can see this is a big mass just above the kidney. This is the kidney. This is just above the kidney. And also there's a big mass in the inferior vena cava. Because of the nature of the autonomous location, they cannot do biopsy because it's a risk of a massive bleeding. So they cannot do the biopsy on this patient. And the urine catecholamine test is negative. This is one to detect the neuroblastoma, which is this kind of location indicated is likely to be neuroblastoma, but this is negative. And another test for neuroblastoma is MIBG scan is also negative. So they diagnosed it as a Wilms tumor, which is the kidney tumor in the kids. And they start chemotherapy. After 6 weeks, I think the tumor shrinks to a certain size. It's safe. It's deemed to be safe to removal. So after removal, they did a histology on these tumor samples, and they found it looks like an undifferentiated neuroblastoma instead of a kidney tumor. So that's the reason they refer this case to the POB, ask for second opinion. So instead of we just look at the histology slide or immunohistochemistry, what we did is using this diagnostic kits we developed with the previous study to see what kind of gene signature this specimen has, right? So you can see this is a hierarchical clustering, okay? And so the similar tumor, they're going to cluster together. You can see this is a rhabdomyosarcoma, this is a Wills tumor, and this is a neuroblastoma. And this test sample is exactly clustered with neuroblastoma. So this is, for us, this should be diagnosis as a neuroblastoma. And this is the microarray result using the Affymetrix +2 array, using the selective 84 genes to look at this. This is the PCA plot. You can see this is the sample cluster with the rest of neuroblastoma, and it's away from this Wilms tumor, okay? So likely this diagnosis, the original diagnosis of Wilms is wrong, okay? It should be treated as a neuroblastoma. So after we relay this information to the German colleagues, and the patient was switched to the high-risk neuroblastoma treatment, including the stem cell transplant. And the patient has been doing well since. So this is a very successful the case for us to use the genomic result to develop useful clinical diagnostic tool for us. And after that, we developed a cancer diagnosis portal in our website. What we can do is anybody in whole wide world, you can do a Affymetrix microarray experiment on your tumor RNA. After you've done this, you can upload the cell file, which is a raw data of the microarray data, to this website. And then this website will use artificial neural networks to train this neural network to diagnose these samples. And the output is a vote for the most likely diagnosis. So hopefully, this project is led by Jianbing He and Qinrong Chen. She left our lab already, but this project, hopefully we can have this portal. So everybody, if somebody is not, just like a previous case, if you're not confident of the diagnosis, you can do such experiment to have a more firm diagnosis. Okay, then I'm going to switch gear a little bit to use this rhabdomyosarcoma to illustrate how to identify a driver. Eventually, we can use that as a therapeutic target. Okay, so what is rhabdomyosarcoma? It is a tumor arise from the progenitor cells of striated skeletal muscle. Okay, and it's the third most common soft tissue sarcomas in children, consisting about 5% of all the pediatric tumors. And the incidence is quite low, okay? It's only 4.3 cases per million children. However, if you have that, that's a pretty aggressive disease. And as I indicated earlier, the metastatic disease form of this disease is pretty lethal still. And histologically, there's two types of this kind of a tumor. One is called the embryonic type. We call it the ERMS. It's about 60 to 70% of those tumors. Luckily, those tumor has a better prognosis. Okay. However, another type is an alveolar type of rhabdomyosarcoma. It's about 20% of the patient. And they have this characteristic translocation involving in the PAX genes. So those patients usually do pretty bad. Okay, their survival rate is only about 30%. You know, those patients usually has a metastatic disease. So this is the previous slide I showed you in our 2001 Nature Medicine study. And we found that the FGFR4 is highly expressed in the rhabdomyosarcoma specifically. And what is FGFR4? It's a tyrosine kinase expressed on the surface, cell surface. It's a receptor. And it's expressed, overexpressed in almost all the rhabdomyosarcoma. And it's recently Paul Meltzer, just used to be on the 5th floor of this building. They discovered from their lab, they discovered that the PAX3 and the PAX3 4CAD is targeting directly the FGFR4 itself. So it's a downstream target of this abnormal fusion gene. And this FGFR4, this molecule, is also expressed during the muscle development. And it's induced in the regenerating of the muscle after injury. So probably this molecule is important in the normal tissue repair pathway. However, it's not expressed in the mature muscle. And it suggests the possible roles in the myogenic stem cells, and suggests possible oncogenic roles in the rhabdo tumor. Okay, in this project, there's 4 specific aims. The first one is we want to determine if this molecule expression is associated with a high stage or the survival in this tumor. And the second is we want to sequence this molecule to see if there's any mutation happening in this molecule, in the tumor too. And another aim is to study the biological consequences of either overexpression of this molecule or the mutation of this molecule. And the last aim is to see if we can use this molecule as a therapeutic target. The first you can see, this is the survival curve, Kaplan-Meier curve of the rhabdomyosarcoma patient. And this is the high expression of FGFR4, and this is low expression of FGFR4. So the FGFR4 itself, the expression can really predict the outcome of the patient. And in this experiment, we use shRNA to knock down this molecule and put it into the mouse. And you can see this is use doxycycline to induce the shRNA against the FGFR4 molecule. You can see the protein has been knocked down, and the tumor really reduced the tumor growth. You can see in this mouse after 31 days. And also in another model is if we inject those tumor cells with knockdown FGFR4 into the mouse tail vein, and usually if the control group has a lot of lung metastasis, but if you knock down this FGFR4, we can really prevent the lung metastasis. So this molecule seems like it has to do with tumor cell growth as well as pulmonary metastasis. And the next question we're asking is FGFR mutated in the RMS? Are they activating mutation? Okay. So we did a huge sequencing study, and at that time we're using the traditional Sanger sequencing. Okay, so this is only one slide, but this is a lot of work involved, okay? And we found that there's a cluster of mutation in this TK domain, tyrosine kinase domain, okay? Especially this 535K, N535K, and V550E, these 2 mutations. And it's about like 7.5% of the tumor has this has mutation in the tyrosine kinase domain. And we didn't find the tyrosine kinase domain mutation in the germline DNA of the patients. So this is somatic mutation, and we want to see what is the biological effect of this mutation in the rhabdomyosarcoma cells. So here is a study that we just put the mutation, we introduced the mutation into a mouse rhabdomyosarcoma model, okay? So you can see this is signaling of the molecule. This is a FGFR molecule, and when the FGF bind to the receptor, it will introduce dimerization and will induce the phosphorylation of the tyrosine kinase domain and start signaling downstream. So here is the parental cell line. This is the parental cell line with only vector control. And this is a wild type introduction, and this is 2 mutant. You can see, this is the serum starved cells. You can see without the ligand, seems this FGFR4 mutation can have self-phosphorylation. That's the reason we predict that this mutation will introduce ligand-independent activation of this receptor. This is published in 2009 JCI. And then we look at the gene expression profile of these mutant clones, and we found that there's the enrichment of the cell cycle genes in those mutant gene expression profile. And this is the GSEA method to see what kind of gene signature expressed. So this is the leading edge genes. It's enriched with the cell cycle genes. And also, if you look at the other end of the spectrum, which is downregulated the genes, it's enriched in the striatal muscle contraction, cell adhesion. So that has to related with the muscle phenotype. So apparently, if we introduce this mutation into the cells, it will induce the genes that accelerate cell cycle and abolish the cell differentiation program. And then this is some in vitro characterization of those cells. And you can see the growth in vitro is, this is the 2 mutant, this is a mutant, this is 2 mutant, and this is the vector control, this is the wild type. You can see the mutant growth is much faster. And this is also seen in vivo. And if we introduce this mutant into the mouse, you can see the mutation will have higher lung metastasis. Okay, this is the wild type and the vector control, and this is 2 mutant form. You can see it has a much higher potential to metastasis to the lung. And we were lucky enough, at that time, there's a FGFR inhibitor available at that time. So one of the compound is developed by the Arid Pharmaceutical. It's called AP24534. The brand name is patented. This drug, you can see, has very potent inhibition effect on all the FGFR receptors in the nanomolar range. Okay, so this is, so we use this to see if we can use this drug to stop the metastasis of the tumor or slow down the tumor growth. And if you look at the target of this drug actually is not specific only to one tyrosine kinase. It's more broad. So if you look at the tyrosine kinase receptor expressed in those tumors, you can see there's a lot of, like for PDGFR and FGFR4 here, and the FLE1, all those, this is all the target of this drug. It's all highly expressed in different kind of pediatric tumors. So we think this is a good drug to use to treat for those tumors. And this is FGFR4. as I shown you earlier, is highly expressed in the rhabdomyosarcoma. And the sensitivity towards this drug is inverse to this expression of this molecule. And you can see this is roughly is an inverse relationship. The higher this molecule expressed in the cell, the lower the IC50 is. That means they are more sensitive towards this drug. And here you can see the same thing, IC50. The lower the expression of the molecule, the higher IC50, and vice versa. And so currently, we are trying to bring this agent to clinic. This agent has been approved by FDA, so we are trying to see if this agent is beneficial to the rhabdomyosarcoma patient. Okay. In parallel, we have other strategy to targeting this this molecule. One is using siRNA. If we using siRNA screen of 4 rhabdomyosarcoma cell lines to identify what is the synthetically lethal combination with this drug. Yeah? This is led in the lab by clinical fellow Jackson and Scott Martin, which works for the chemical genomic groups. And another way we can target this molecule is to develop the antibody on chimeric antigen receptor strategy to do the immune therapy. We can either conjugate the antibody with a toxic payload to target the tumor cells, or we can use chimeric antigen receptor to activate the T cell or NK cell to kill the tumor cells. So this is the ongoing lead by Basker in the lab and Remus Orentis is in the POB. And another approach is we just want to bring this drug into clinic. So we will say, can we use FGFR4 as an indicator, as a biomarker to say which patient can be treated with this inhibitor, tyrosine kinase inhibitor, to benefit those patients. So this is led by a bunch of clinicians working in the POB and also the ARID, which is the pharmaceutical company making this compound. So in summary, I showed you FGFR4 is a diagnostic biomarker in the rhabdomyosarcoma, and the high expression of that is associated with an adverse outcome in those patients. And the inhibition of the wild-type FGFR4 will result in induced growth and lung metastasis. And this is the first report of the mutation in the receptor tyrosine kinase in the rhabdomyosarcoma. So, and 7.5% of those patients potentially can benefit from this therapy. And the mutation resulted in the transformation, increase of growth, and the serum-free survival, invasion, and metastasis, in vitro and in vivo. And here, the cells, if harbored, I have shown you cell harbor the mutation will show the increased sensitivity to the this agent inhibitor to inhibit this molecule. And we're going to bring this to the patient. So the last part of the talk I want to introduce you is a new technology. It's really can revolutionize the clinical practice, especially for those high-risk patients. This is a next-generation sequencing technology, also called massively paralleled sequencing technology. Okay, so this slide just show you how this technology works. Okay, the concept is very simple. I think several of you went to ADC to see the machine. And I already showed some slide of that. If you already see that, just bear with me. I will go through this very quickly. So let's say this is genomic DNA or RNA molecules. And the first step is we can fragment those big molecules into small fragments, into hundreds of bases. And then we can do a cell selection. That's just for easy of the PCR up in the library. And then we can ligate the adapter to each molecule, making this is called the genomic DNA library. And after amplification, and we can put down those library on the sequencer to sequence each read. Each small pieces, you can read on the sequencer what the DNA sequence is. And then you can align the bioinformatically using computer to align to the reference genome, which is a human genome. And then you can deduce, you can put back original DNA molecule, what the sequence is like. So that's just the concept. It's very similar to the early days, the shotgun sequencing. Okay, you chop them all up and you sequence each piece and you put them back in silico. So that's the concept. What type of information you can get from this technology? This slide, it shows the type of information you can get from the DNA side, the genomic DNA. If you have a genomic DNA, this is the information you can get. The first one is a point mutation. If you have a point mutation, after you align all your reads towards the reference sequence, you can see the sequence, the reference sequence is A, but your alignment is also C. That means you have a point mutation in your sample, okay? And the same similar concept, you can detect the small indel, either small insertion or deletion. You can detect that. Another thing is you can count how many reads in a particular region. For example, in this one, in this case, there's no reads in this region. Okay, nothing mapped to this region. That means they probably have a homozygous deletion in this region. Okay? And another case is a hemizygous deletion. If you lost one copy of your chromosome, you will see something like that. Okay? And of course, you can detect again, you have an abnormal high coverage on a certain region. You can detect that. And another important thing is, you know, in this case, this is a chromosome 1. This is a material DNA sequence from chromosome 5. And if you see in your data, some molecule has part of the sequencing coming from one chromosome, another part from another chromosome, that means there's a translocation. There's a breakpoint here, okay? So bioinformatically, you can detect all those information in one sequencing experiment. Another thing is you can detect is non-human sequences. If you map all your reads to a gene bank, sometimes you can find, you know, there's a viral sequence in your sample. That likely, that means there's a viral infection in your sample. So you can also detect the non-human sequence. Okay, this is on the RNA side. It's very similar to the DNA sequencing. The only difference is this is more complicated. The reason is, see, this is a pre-messenger RNA, right? This is a mature messenger RNA. And in the cell, the splicing machinery will splice those black part, which is the intron. They will splice it out and to make this matured RNA. And when we sequence, we only see the mature RNA, right? But when you map back to the genome, it's more challenging because you have a lot of the intron sequencing missing. So you have to insert the gaps to be able to map those reads to the proper region of the human genome. So this is a more complicated case, but nevertheless, we can do that, okay? So the information we can get from the RNA sequencing experiment is we can have digital gene expression we can detect the expressed mutation. If it's a mutation in the DNA, if it's expressed, we can detect it. And we can, of course, study the alternative splicing events, which in the past, this is no way to study that, okay? You have to have a prior knowledge to design your probe to detect your, this kind of variance in your samples, which in the sequencing, using this sequencing technology, it's very easy. You can just do that. And also you can detect the expressed fusion transcripts and the RNA editing events, novel transcripts, and encoding RNA. This is all independent of prior knowledge. You don't need a prior knowledge to design your probe. You can just sequence it, you can see it. That's the power of this technology. So this slide just to summarize what I just told you. And the DNA, you can have different kind of sequencing. I will get into detail. And all this information, copy number, gene arrangement, even the methylation status of the genome, and the mutations, you can detect those. One experiment. RNA, the expression, chimeric genes, splice variants, novel transcripts, damage mutation, you can all detect in the RNA sequencing. And all those experiments can be done in one platform, okay? So very simple. One platform, you can do all those experiments, depends on what your question is. And so we use this kind of platform to discover the biomarkers, the drivers, and hopefully the therapeutic targets. Okay, this slide just show you the most popular next generation sequencing instrumentation out there. Okay, this is a 454 from Roche, and this one is a fairly low throughput compared to the other machines, but it has a longer sequencing reads, okay? And this is Illumina, which is the most popular next generation sequencing platform. And it can have a huge throughput. We have one in the lab, it's the Illumina HiSeq 2000, which can sequence 600 gig base for 2 weeks, in 2 weeks. So it's a huge throughput. That equivalent to how many, it's 200x coverage of a whole human genome, right? So it's a very high throughput platform. And this PAX Bio or Ion Torrent, this is another, actually this is a typo. It should not be Ion Torrent, it's a PAX Bio. This one is a single molecule sequencer, okay? Has a very long read length, but fairly low throughput currently. And this platform, unfortunately, we used it before, but now it's outdated. We're not using this anymore, but nobody using this anymore, as long as I'm concerned. And same with this from LabTech. And these two platforms, this is also owned by, made by Life Technology. This is called Ion Torrent. Just remember this, called Ion Torrent. One is called PGM. This is a smaller version of this. This is called Proton. But this platform is using semiconductor sequencing technology. So I will tell you a little bit why this is a very powerful way, especially in the clinical application. Okay, here is the type of sequencing experiment we usually do in our lab. There's a whole genome sequencing, whole exome sequencing, and the whole transcriptional sequencing. Okay, whole genome sequencing, the advantage is you can acquire the most complete information in one experiment, including all the things I'm talking about. But the disadvantage is it's still very expensive. It takes about $6,000 or $7,000 per whole human genome currently, and not counting the labor, okay, just the consumables. And another challenging for whole genome is difficult to interpret. because it's so much data. Where you're looking at, you are looking a needle in a haystack. So it's very hard to interpret. So another way to approach this is we're using the whole exome sequencing. And the advantage is less expensive. It's pretty easy to achieve high coverage because you're only pulling down the region of interest to sequence. You're not sequencing the whole genome. So you can increase the coverage. However, the disadvantage is the lack of coverage outside your designed area, right? If you're interested in a SNP that is outside of coding region, usually you're out of luck if you're using the coding region probes. And also in this information we got from the exome sequencing is we do not have structure information. You lost that structure information, okay? And the whole transcriptome sequencing, we can identify all the things I was talking about, but the disadvantage is it's very uneven coverage because it's determined by the expression level of gene. High expression gene, you see it over and over, very high coverage, but the rare transcript, for example, like a transcription factor, it's very hard to detect. You have to sequence pretty deep. In that case, it can be very expensive. These slides just show you how the genome partition works, the exome sequencing. Okay, so in the lab, we use a solution-based platform. So this is the DNA, genomic DNA. The first thing we do is to share the DNA into fragments, and then we design the probes to target a specific region we're interested. In this case, if you're using the whole exome sequencing, means you only target the protein coding region is only about 2% of your whole genome, right? So this is about 64 megabase instead of 3 billion base you have to sequence. So you have this probe, those blue dots represent the biotin molecule. So it's labeled with biotin. And what you do is mix these two together in one tube to do the hybridization. And eventually you use this streptavidin coated beads to pull down all those molecules with biotin. Yeah? So the region of interest is pulled down with those probes, while the other region gonna wash away during this process. And then you elude those targeted region and you sequence only those things. And then that's the things behind it. So currently in the lab, we use this kit from, I think it's from Roche. And we sequence about 64 megabase of region of exome. And this is containing about 20,000 genes, protein coding regions. And we can reduce the cost for each experiment. But again, we do not have structural information. And this is the first paper we just published in the POLUS 1. And this study, I'm going to use this study to illustrate how we use this technology in our research. And we use the next generation sequencing to identify the novel targets in one of the neuroblastoma patients. And this patient is treated in the pediatric oncology branch. It's a 19 years patient, which is very unusual for a neuroblastoma patient because like 90% of patients happen, their age, diagnosis age is under 10 years old. So 19 years old is a young adult. It's very rare. And this is sample we took, the first sample we took is a bone marrow diagnosis sample. Okay, it's full of tumor cells. It's already, the tumor already metastasis to the bone marrow of the patient. So we took that first sample. And then after 4 months treatment, and this patient has gone through the surgery because the tumor is too big to cause the difficulty of her life. So we took out the tumor. This is the part of the kidney, and this is the tumor. You see it's extensive necrosis, but there's a lot of viable tumor cells on the peripheral of the tumor. and this is the histology of the tumor. And after 3 years struggling, she went through a lot of therapies, and all different kind of therapies, very aggressive therapy, okay? Eventually, unfortunately, she died of disease. At the autopsy, we took liver mets. This is the liver mets from the patient. So we have 3 samples from this patient over about 3.5 years. So we did a genomic study to ask the question is, can we identify the target for this patient? If in the future a patient coming in here, can we identify something can help the patient? So in this study, we combined the whole genome and the transcriptome sequencing. So this is the experiment design. And this is the patient, the liver mets at the autopsy. We got the DNA from it. And the same time, we have skin DNA as her genome line. So we did a whole genome sequencing. We identified about 8,000 somatic variants in this patient, in this tumor. And we use annotation methods. This is called ANOVA. It just tells you where the mutation happens. So we know that there's a 61 non-synonymous mutations in the tumor. Okay, non-synonymous mutation means those mutations will result in protein change. Okay, it's not silent, it's protein change mutation. And we use another different method to resequence all these 61 mutations, and we validate 44 of them are true mutation. They're not false positive. And then we took the MED1, which is the bone marrow DNA. We look into those DNA, say if the mutation are those mutations there even at the diagnosis, okay? And consequently, we took the multiple sections of the primary tumor, and we say if there's a heterogeneity in the tumor because the tumor is so big, okay? And from there, we found that there's a 14 mutation that is common, but this tumor, interesting things, accumulate 30 unique mutations just for these liver mets. That means during about 3 years treatment, there's another 30 mutation accumulated in the tumor cells. That's kind of interesting. You think how fast this mutation comes about, okay? And at this stage, we integrate the whole transcriptome sequencing and data, and we looking for what is the expressed mutation. Our rationale is if it's an oncogenic driver event, it has to be expressed in the tumor. So we identified these 3 genes. And this is the data just show. This is a very high level looking of the genomic, the genome of this tumor. This is the whole genome sequencing data. And the different track represent the different information. For example, the odd track here is all the mutation I was describing. There's 44 mutation in this sample. And this is copy number. And this is heterozygosity track. And this is the variance track with all the variants different from the human reference genome. And these lines represent the translocation, and those things is the interchromosome translocation. So this is a lot of change in this tumor genome. And we can also detect the chromosynthesis, which is the chromosome shattering event in this tumor. You can see some focal rearrangement, very, very complicated rearrangement. There's translocation, inversion, deletion, insertion, all sorts of things happen in a relatively short region. This is not only, say, one chromosome, but multiple chromosomes. That means this cancer genome is totally rearranged, okay? And in the literature has been reporting this gene is mutated very often in the adult form neuroblastoma. So this is published last year. So we try to look into these genes with our whole genome data. And you can see how easy we can get this kind of information. As I said, this y-axis depict the sequencing coverage of this tumor. And this is just the X chromosome coordinates. You can see that the coverage just immediately shows in this region, there's a deletion. So this is regular coverage, is about 80X, but in this stretch, it's only less than 40X. It's about half of those. So that's indication of a homozygous deletion, okay? So we designed a genomic primer to amplify this region. If there's a homozygous deletion, we can design a primer to flanking this region to do PCR. Because this region we predicted is about 15 kb. Regular PCR, you should not see any band like here, right? The normal skin, you don't see the band. But for the tumors, we all see this 220 abnormal band. And we subsequently sequenced this PCR product. We found that this is exactly the breakpoint that we predicted from the whole genome sequencing. Okay, when we look at the expression things of those genes, this is all the shared mutation, that 14 shared mutation. You can see most of them are expressed, has some expression in all the tumors. Okay, this different color represent the different tumors. Usually they expressed. And this is allele fractions in the expression data. That means, if it's expressed, how much fraction of the allele is mutant allele, how much fraction is the wild type allele. You can see most of them are pretty balanced, but there's 3 genes seems has a very high mutant allele expression, especially in the MED2, okay? So that indicates those are important genes for the metastasis tumors. And those are unique expressed variants. You can see it's only unique to the, as expected, they're only unique to this MED2, not in the other samples. So we concentrated on this molecule, which is called the lysophosphatidic acid receptor 1, which is a G protein coupled receptor. And actually there is a compound can target this interaction with its ligand with the receptor. That's the reason we picked this molecule to do further study. And in the literature also indicated this molecule is important for the neurodevelopment and has functions in the cell migration and differentiation, and also important in the cell survival. And you can see this molecule is sit on top of a bunch of very important pathway in the cells. So the mutation is located in the second intracellular loop right here, okay? And it's predicted to be damage mutation. So we put this mutation into a cells, try to see the expression profile. We found this induce a migratory signature in the cells. And we look at the cell, indeed, this mutation will result in a high migration in a Boydin chamber assay, but not much difference in the growth assay. And this just shows that this molecule, the signaling is through the ROR pathway, and we can abolish this effect with a ROG inhibitor. So the translution genomics, I'm just go very quick. I think the time is up. And that study showed that we can use this technology to identify the trackable targets in the patient. So now we try to push this into the clinic. There's 2 protocols in our branches we are doing. One protocol is we take the samples from all the pediatric patients, we archive them, we sequencing them. Hopefully we can practice saying what is the best way to identify target in those patients. And this protocol, actually, we're using the microarray signature to stratify the treatment for the patient. This is an ongoing protocol. So I'm going to just skip all this. This is just how we implement these two protocols in the clinic. So eventually, what we want to do is if we have diagnosis samples, we can take the sample, do the genomic profile, and identify pathway and molecules, and then we hopefully can identify the targets. And this is the technology I want to introduce. So this is a semiconductor sequencer. Each well it can host one sequence, one bead. And then, every time you elongate one nucleotide synthesized in the or the DNA molecule, you actually release a proton. All those little wells, it's a pH meter. You can measure the pH change to detect what kind of sequencing is. So this is a very powerful technology, and it's so quick. Usually now we have to wait 2 weeks to wait our sequencing run finish. This one only takes 2 hours, and you can sequence very fast. This is the perfect platform we can use in the clinic. So the idea is, in clinic, we have all different heterogeneous population of the tumors, but if we can use the biomarker to stratify what the people have a good signature, we can use standard therapy for those patients. But if you have a poor signature, we can identify exactly what's the target specific to this patient, and we can specifically target to this to increase the survival chance of the patient. So that's the idea, through those exercises. So the conclusion is I have shown you that we can use integrated analysis of the genome to identify the biological relevant diagnostic, prognostic biomarker, and the novel target for therapy. And there's a powerful emerging tools of those next generation sequencing technology can determine the complete genomic portrait for any tumors in the next 5 or 10 years. And they will lead to the identification of the key drivers for each individual tumors. Hopefully, we can use that for therapeutic purpose. And this is just the acknowledged slides. And this is a huge effort, involve a team science. Okay, this is all the biologists working in the lab. Those people are previous lab member. And we have a huge bioinformatic component in the lab to process data. You can imagine in the old time, microarray only have like 100 megabytes of data per experiment. Now the sequencing is using terabytes to measure the data size now. And this is all the collaborator in NCI and the other institute. Thank you for your attention. Sorry, a little bit over time, but any pressing questions? I know it's late. Yeah.
In the interest of the hour, I think
Okay.
we'll just close.
Great. Thank you very much.
Thank you.
Okay. Thank you.